Contralateral C7 transfers for spasticity has been a contentious topic among hand surgeons and neurosurgeons. However, its role in lower motor neuron is fairly well established, especially in pen plexus injuries, and is a known strategy for most centers, especially in Asia. My name is Vaikunthan Rajaratnam, and I'm going to talk today a little bit about the philosophy of how the central nervous system is affected by contralateral C7 transfers and how this has a part to play in neuroplasticity and adaptation that occurs after stroke. And I will go through some of the literature, the evidence there, and a personal experience with the use of contralateral C7, early experience. I feel that this is an important strategy that we will need to keep in our armamentarium, and there's much more work that needs to be done on the role of contralateral C7 transfers and its impact on the central nervous system as the patient continues to rehabilitate and recover following a stroke.
Our brain is the seat of perception of our universe and the seat of volition and how we execute function. And in this information processing system, which I have modified from the models both in computing and in the brain, you can see how the mind, which is a function of the brain, perceives our universe through our senses, and the peripheral nerve is one of these tissues that provides the senses, and is also the tissue that executes the response through a motor action. The other functions which we won't go through, but for us to understand how we impact the peripheral nerve, this is a good model for us to look at. We are familiar with the various pathways. It is important for us to revisit how the peripheral nerve is connected to the central cord, to the central nervous system, to the spinal cord. The lamination of fibers are represented not just only in the brain of the homunculus. Similar homunculus are seen in the spinal cord. This is important for us to understand because interventions can occur at various places, and this organization and complex synapses are important for us to utilize in understanding and in managing nerve injuries. To be able to manage post-stroke spasticity, it is important to understand the pathophysiology of spasticity. It is the reduction in the inhibition of the upper motor neuron on the lower motor neuron, which results in a velocity-dependent increase in the tone of the peripheral muscles with hyperexcitability, and also important to realize the co-contraction of antagonists and agonists, and the neglect of which will result to the presentation of muscle contractures and will result in deformity. The common causes of spasticity are cerebral palsy, spinal cord injuries, and stroke. 30% of stroke will end up with spasticity, and about 80% of spinal cord injuries ends up with spasticity.
My philosophy when approaching problems for spasticity is to understand the cognitive load that spasticity produces on the patient. You have to examine the patient as a whole, have an understanding of your patients, and this is an important concept before you embark on surgical intervention. Because of the nature of spasticity and the impact on cognitive load, we must understand the concept of the ideomotor axis. And this is something that you need to understand to see how a peripheral surgery from a neurectomy to a correction of deformity can have significant impacts centrally, but also in the lower limb. So there is, when we make a motor action, there is a cognition that we decide we want to do an action. And the action is then carried out through the neuromuscular system from the muscles to achieve the goal of our movement. And from that goal, when we're able to grasp an object, we have a reward. That is the reward of able to have the sensory feedback, the haptic feedback of having achieved that goal. And that provides the motivation to continue with motor action. And this is an important concept to understand, especially when it comes to rehabilitation.
To understand the human grasp, which is an important aspect in upper limb surgery, we need to understand that there are neurons that would fire from the command center in the brain. And this has been shown through some studies. A single neuron for a complex task like a grasping action, a single neuron has been trained through a process of neural coding to fire multiple circuits to produce the complex motor function to produce the activity of grasp.
Based on the framework that I've just explained, this is how I would assess my patient for a clenched fist. So to be able to fully understand, we need to understand the causes of that deformity. There's a physiological cause, which is the hyperexcitability, and we need to see which of those muscles in particular is affected in the hand to produce that deformity. Then the pathological causes for the um, deformity needs to be evaluated to understand the neuroplastic changes that occurs. And here we also will look at the length and the amount of intervention that has occurred early, whether there has been disuse atrophy, is there contracture, and the functional evaluation of the patient. And a thorough understanding of the patient's expectation is crucial here because otherwise your type of surgery and your outcomes are going to be very poor. And then finally, to make that decision on what kind of surgery and where we're going to do is the anatomical evaluation of the impact of spasticity in the hand. So which are the muscles from the FDS, FTP, FPL, FCU, FCR, and the intrinsic muscles. So we go through that very systematically, and I won't go into the details, which I'm sure you would have already had this in the earlier part of this conference. Yeah, I'd like to just kind of put into a table on how we use the various intervention once we have selected a candidate for surgery or in the process of selecting. So the role of Botox injection in my practice is mainly in early and moderate spasticity. One is to obtain temporary relief, but I use it more of a diagnostic tool. When they appear to me and it's been referred whether we could do surgery, we give them a diagnostic tool where we inject the muscles that we think that are affected with accurate palpation. And once that is done, we wait for the patient to come back and tell us how do they feel, whether it was any good, any better. We must make sure that the patient has had some effect. And we'll tell them that this doesn't last within 2 to 3 months, the spasticity would return. And from there, we then move on to neurectomy. So once I've made a diagnosis, the patient feels that there is a benefit from the intervention, then we go ahead and do the neurectomy. Then we have various other things like tendon lengthening or tendon transfer. So this is dependent upon the amount of chronic contracture that has occurred, and then we consider whether it's going to divide the tendon, we're going to lengthen it, or we're going to then balance it with the use of a tendon transfer. We'll see some with the cases. The other state is when there's low function with severe deformities, as in the clenched fist that we will discuss. Then we think about the address the chronic deformity from fixed contractures, both of muscular tendinous unit and also the joint. And then we will consider how we could improve from function and cosmesis. Here's the algorithm for surgical intervention. So the initial assessment is done, then we decide whether there's a non-surgical intervention role here, and we use a multidisciplinary team, and I listen to my therapists who spend time with the patient, they understand the patients, and they have the final say in my practice whether we proceed or we don't proceed, apart from the physical assessment. And then we determine the surgical need. How can surgery help this patient? And in process, we make sure we have a relationship with the patient with the 2 or 3 visits before we then plan the surgery with them. We manage the expectations. That is crucial component. And then we explain to them the post-operative rehabilitation that is required. And in this sort of situation, the use of splinting devices till tissue stabilization occurs. Contralateral C7 transfers for the reanimation of the upper limb has been well established since 1986 for brachial plexus injuries. Recently, it has also been used for spasticity and has documented that the donor defects are compatible with function and has significant improvement in functions in the upper limb.
Recent studies have clearly shown the anatomical basis for the outcomes seen in contralateral C7, and this review is worth a read to understand how the contralateral C7 produces functional outcomes in the motor of the targeted muscles. In this landmark paper by Sheng et al. From Shanghai on a randomized controlled trial showed the superiority and functional outcomes for contralateral C7 transfer as the intervention in post-stroke spasticity with outcome measures both in the Fergal-Meyer score and the modified Ashford scales with improvement. Donor morbidity was minimal and was recorded and was compatible with function. This set the stone for the extensive use of contralateral C7 over the last 10 years in the reanimation of the upper limb in post-stroke spasticity. In this recent paper by Li et al. Had shown the structural changes that occurred following contralateral C7 transfer using tectographic MRI techniques, showing that the improvement in function was secondary due to structural changes in the pathways as a result of this nerve transfer.
This slide from the paper shows what happens to the connections in the brain. Before surgery, you can see that the corticospinal tract on the injured side shows limited activity as a result of the trauma. But after surgery, there's a new connectivity across the brain's corpus callosum, demonstrating successful nerve transfer and the potential for improved motor function. So this provides the basis, the anatomical basis for what happens centrally following contralateral C7, and is something that we need to look at, and the deep neural networks that occur in the brain to facilitate neural plasticity is going to make a significant difference in how the outcomes from contralateral C7 is. There are things that we may not understand, but the availability of an anatomical connection between the right and the left side through the contralateral C7 would facilitate, as shown by here, the added connection between the right and the left brain through the corpus callosum, and this can help in the rehabilitation in neuroplasticity.
So, in order to understand how the knowledge is evolving on the role of contralateral C7 transfers for spasticity, we conducted a scoping review using the terms contralateral C7 and spasticity. Obviously, there are a lot of publications on the role of contralateral C7 transfers for lower motor neuron lesions. However, there are only 7 papers that fulfill the criteria, and this is a summary of the findings of this paper. Most of these papers came out from China, bar one, which was a review paper and not primary data. A lot of the papers were also relating to surgical techniques of the contralateral C7, the paraspinal, the prespinal, the pretracheal, the prevertebral, and there was only one paper on the use of the both contralateral C7 and L5 to S1 transfer for hemiplegia. The landmark paper is obviously the randomized controlled trial of 36 patients, which I've mentioned earlier. So it is worth your while to look at this table if those of who are interested in to see what is the evidence for contralateral C7. Obviously, this shows there's a tremendous scope for further research with further observational studies on the role of contralateral C7. Results that you can see, there's a significant and sustained motor recovery. There is a very predictable reduction in spasticity that's quite sustained for up to about 5 years with a structured rehabilitation program, including of magnetic and electric therapy stimulation that has been shown to improve and assist in the rehabilitation post-surgery with the Huashan protocol. Donor side effects are very clear. Is in most literature there is minimal morbidity, and the procedure is safe and effective for use.
We'd like to present this 37-year-old male who had a right upper limb spasticity. As you can see here, it's quite moderate spasticity, and this is a result of a head injury with road traffic accident that we saw about 4 months post injury, and he had the difficulty in using his right upper limb. And if you look at his face, you can see there is an increased cognitive load in an attempt to do voluntary movements, and the spasticity is quite significant. The main findings are the shoulder and elbow functions were good, but we can see that the forearm is pronated, the wrist is in a relatively neutral position, and the thumb has got a slight thumb in palm deformity. And there's stiffness noted in the extensor pollicis longus and flexor digitorum superficialis. And the thumb can be brought to full extension, and he also had global aphasia. And based on these characteristics, we planned a contralateral C7 using a sural nerve graft to bridge the gap, as we did not want to do too much of dissection, to do a prevertebral route, to do direct coaptation of the contralateral C7. In this slide, we look at what are the indications for contralateral C7 in spasticity. So for my understanding of the problem and what I have read through in cognitive neuroscience and in central nervous system synapses and neuroplasticity, if you have a chronic spastic paralysis of the upper limb, there is not improving with conservative management, and the injury is unilateral and not bilateral. However, we have also done some form of nerve surgery in terms of neurectomies for patients with focal dystonia, and in a couple of months I will be doing a case of Wilson's disease with a similar form of spasticity, and we're going to try to see whether contralateral C7 or neurectomy will be useful. There must be significant functional impairment, otherwise I don't think this is a surgery to be attempted. And I would add, if there is significant aphasia in conjunction with the speech therapist, to see whether the neurectomy from the C7 on the affected side and the contralateral C7 transferred from the normal side would improve aphasia, as we have a case that we can see there is a slight improvement. And again, the duration of the paralysis, as you know, there is a flaccid stage and a spastic state. Usually, I would probably wait between 6 months to a year till we see a plateauing of the spasticity, but making sure there's sufficient intervention in terms of splinting and stretching to keep the spasticity relatively stable without the formation of contractures. So once the contractures are formed, then the effect of of any form of nerve surgery is going to be reduced, and I would wait for a plateauing of the clinical state before offering surgical intervention in the form of contralateral C7. And there must be all the deformities should be correctable with relaxation. If there are fixed contractures, then this may not be the surgery of choice. Now, the spasticity has to be moderate to severe. Mild spasticity, I don't think would benefit from this form of surgery. And if you see there's a possibility of increased cognitive load on the patient, the cognitive load, as I explained earlier on, is a result of hyperexcitability of normal neurons around the area of the upper motor neuron lesion that makes it difficult for the patient to perform a motor task. So establishing the cognitive load, sometimes you can see this in the patient's face. You need to ask that he takes too much of an effort and that he would give up because the rewards are not there for the effort put in, and that's what happens, and the neurorehabilitation becomes a difficult task. Now, there must be obviously a functional impairment, otherwise you should not be considering this form of surgery. It must be significant amount to affect activities of daily living. Also, if there is a poor progress in rehabilitation, I feel that this procedure can increase the outcomes from rehabilitation. It primes the central connections, the neural connections, synapses, and plasticity to help with neural rehabilitation. The other thing is, if previous conservative management have not been very useful and there's poor progress in rehabilitation, and I would add another indication: if the patient is very, very motivated and is keen, understands the rehabilitation and the limitations of this surgery, then it will be worth the while to consider. The other thing to look at would be the donor nerve. The contralateral C7 obviously must be available, and you must, if you want to keep the procedure simple and do a subcutaneous tunnel to cross the opposite side, then the pseudo nerve graft helps to bridge the gap, because it won't be able to do primary coaptation unless you want to take the prevertebral route, which has got its challenges. However, there are some who have tried, especially in low motor neuron lesion in pediatrics. They have used allografts like exogen to bridge the gap. Then you must also look at the anatomy, whether is suitable. There's the anatomy of the neck is fairly good bed for a transfer, especially if you're pushing a graft. The bed must be sufficient vascularity to allow for the success of a nerve graft. And obviously the availability of a pseudo nerve if you're contemplating a graft. However, if there's an allograft, you could do that. So the justification for us to perform this contralateral C7 in this patient was we have strong evidence in MRI that supports contralateral C7, and the benefits would be it would reduce spasticity on the affected side because it's a neurectomy, it's a high neurectomy of C7, and that would get immediate results as we show in this case. And there is a significant improvement in the literature that there is improvement in motor function, and therefore the data that we have, both MRI and clinical data, that validate the proposed surgery. The limitations of this procedure is, one, there's a long delay in motor recovery. It's not totally predictable, but I feel that the need reducing spasticity from the neurectomy of the affected C7 is beneficial. And if you're using our nerve graft, then there's two neuroropathy sites, and that comes with its own problem. And there's been a fear in the West, especially of taking the contralateral C7, which is the normal part, and that danger of producing significant motor and sensory deficits. And I've been using this a lot in low motor neuron lesion, and I've never had a single case. And the literature also says there are hardly any motor deficits or permanent sensory deficit, most recovering within 3 months. And obviously the surgical complication, especially if you're taking the prevertebral route or the intraspinal route, which are higher risk because they involve spinal surgery with bleeding, scarring, and technically more demanding. But you must realize the contralateral C7 is a complex surgical procedure. I think most nerve surgeons are quite comfortable, except those who have never done contralateral C7, but it's a very easy procedure to learn for nerve surgeon. And the handling of the nerve is paramount. And again, this is not a problem for nerve surgeons. There is some uncertainty in the long-term outcome. We're still early days. I think more research needs to be done, but we need to push the boundaries for this type of surgery.
He just pointed and say, art, it means nothing. No.
He cannot hear anything.
He hears, but he
Cannot say. Okay, he's got an aphasia.
This is the patient positioning. for the contralateral C7 done under general anesthesia, and ensuring that within 10 minutes there is no neuromuscular blocking agents, as we will be stimulating to detect the contralateral C7. This shows the C7 donor, the contralateral C7 that has been divided. The loop is around the distal end, and the forceps is holding the proximal end of the contralateral C7. Then the pseudo nerve graft will be coapted to that. This is the patient immediate post-op. You can see a complete reduction of the elbow spasticity as compared to the pre-op. And here you can see the wrist is also loose. And here you can see the finger spasticity has reduced, but not significant as much as in the elbow, but you don't see a spring back sign. The pronator spasticity has been significantly reduced as we compare with the pre-op state. And on the opposite side, you can see there's no motor deficit following the contralateral C7. There's full wrist extension, finger extension, and elbow extension. And there was no significant sensory deficit in the area of the C7. There was some minimal sensory loss, but otherwise there was none.
Can he say his name? Huh? Can he say yes?
Mong em mai nữa.
This is his post-operative 1 month motor outcome. You can see that he's able to move the hand with less cognitive impairment, a load, less effort because of the neurectomy. The neurectomy has reduced his spasticity. And note on his left upper limb, he has no motor deficit. He's able to use his hands for all the functions, showing that the contralateral C7 has got very little donor morbidity following the transfer. You can also note that he obviously hasn't got full function there. This is just a neurectomy and the transfer has been done. This is going to take the next 6 months to a year for it to the plasticity to occur centrally to improve the function in the right upper limb. But immediately you can see the cognitive load that's reduced.
This diagram explains the various routes for contralateral C7 that's currently in the literature. In our case, we use a subcutaneous with a sural nerve graft. The prevertebral route can be performed without the graft, but with the dangers of injury to the vertebral artery, and this can be it's a bit of a blind procedure. We are now looking at the posterior approach, which is through a laminectomy and an intradural contralateral C7. This photographs of cadaveric dissection is a proof of concept of a contralateral C7 using a laminectomy and an intradural approach. The dura is open, as you can see, is retracted to the side. You can see the rootlets of the dorsal and ventral rootlets of the C7 on the affected side, and then we have dissected the contralateral C7 distally as it exits the spinal canal. This is about 12 to 14 millimeters in length. And then in the next slide, you can see this has been then transposed over the posterior aspect of the spinal cord and sutured to the ventral and dorsal roots, which were divided very close to the spinal cord. And this is our proposed, and we look forward to performing this clinically. There have been some studies from China that they have already performed this. We feel this is a suitable way of doing it without any anterior approach, and we will look at the proof of value from this with further studies. All right. Now we're going to look at measuring
that the management strategies for spasticity in the upper limb and lower limb is evolving, and the role of neurectomy, highly selective neurectomy, and nerve transfers are improving, and there are more work that needs to be done. However, in the measurement of outcomes has been quite unsatisfactory with the current instrumentation that requires to have more fine instruments to measure the targeted interventions that have been done and not just for pure global outcomes. It's also important to understand the experiences of the patients as the cognitive load and spasticity affects function significantly. There requires to be more interaction in the multidisciplinary team involved in the care for post-stroke spasticity. That requires counseling, education, and targeted research is needed for us to be able to gather evidence for the importance of surgery in post-stroke spasticity.
Now we're going to look at measuring outcomes in peripheral nerve surgery. Now, generally, we have been assessing outcomes in peripheral nerve surgery based on more of a physician-centered, especially in terms of nerve injuries, both peripheral and central. The impact is beyond just the patient, the biophysical, and actually includes community and all stakeholders. The Engels psychosocial model introduced a very important component into the measurement of impact in healthcare. But we need to go beyond. And recently we published a paper where we included another component beyond the biophysical, the psychological, the social, but the economic impact. And this is a very important aspect upon how people are affected by the disease, the injury, or the healthcare intervention. Current outcome measures generally are very motor, sensory, and pain assessment, and measuring only these three domains. But this is limited, and there's a lack of sensitivity to how it affects the patient's experience. There's insufficient psychological and social impact and economic impact are being measured, and there's an incomplete understanding of complex injuries and how they impact the individual, the community, and globally. And here's a video I encourage you to watch, and this looks at the qualitative aspects of how brachial plexus injury, span plexus injury impacted two individuals in Cambodia. This video, as I watched it, it has been published, was that it affected my perspective on how much we are doing for our patients. I thought we weren't doing very much, but after listening to the stories, the narrative, it motivates me to continue with brachial plexus surgery. Now, measuring neuropathic pain is generally there are various tools. What we need is a simple tool that is usually utilized by anybody in the field to measure neuropathic pain. Now, when we start looking at PROMs and PREMs, now PROMs were patient-reported outcome measures, and it's well explained here, but PREMs became experience measures, but generally it has been used, PREMs have been used mainly for the delivery of healthcare services, not on the impact of the individual, and this is where we need to look into in more depth. So when we are assessing complex injuries which produce or complex problems, like not just injuries but also diseases like brachial plexus, brain injuries, spinal cord injuries, strokes, cerebral palsy, they produce challenges in terms of our current methods of evaluating the impact. We are not only just measuring the patient's biophysical and psychosocial, like using functional independent measures, DASH scores, the WHO DASH 2.0. All these are very much focused on the individual domain, but we need to look beyond that. Now, coming back to spasticity per se, spasticity is a difficult measure, and anybody who's done the measurement of spasticity using these instruments know the challenges. I've done it. It can take up to 40 minutes to an hour, and it is very complex. We need to look at different instruments that can measure it more holistically. Now, I think it's very important to incorporate qualitative research. And here's where mixed method research, both quantitative and qualitative, need to be incorporated into measuring the outcome and impact of nerve injuries. And I think there's a need to develop patient-reported outcome measures that are more aligned to the patient's needs, and these can then inform patient-centered care. Now, pre and post surgery assessment, therefore, must include this. And this is where lived experiences with in-depth interview of patients pre and post and focus groups incorporating all stakeholders involved with the patient to better understand the problems and the impact our interventions has had. And we must take into account patients' expectations and concerns, and this has to be incorporated within our assessment tools. And by this, we can then identify areas for improvement. Now, longitudinal studies are very important because some of our impact takes a long time to happen. And this is why I think transdisciplinary research and participatory research is important to understand long-term impact on surgical intervention, identifying factors contributing to recovery, and developing strategies to improve and engaging all stakeholders. This is a future, and I think stakeholder engagement in understanding who are impacted by the individual is important so that we can understand the various factors and help the patient to return to the community in an optimal fashion. And we need to have deductive tools in the clinical setting. How can we rapidly integrate technology to be able to do patient-reported outcome measures without consuming too much time? And here is where I think the role of ambient clinical recording with generative AI can help us with this. Patient-centered care planning is useful, and here's where again AI can help. And we therefore need to train and educate our professionals. Now we need to integrate all these findings, the multimodal in nature that is collected from the ground, and this is where data engineering is important. How we collect this data hassle-free within the clinical context and incorporate that into our electronic records for good quality qualitative research. And the emphasis should be on patient-centered care. And in conclusion, therefore, there's a big gap. It is important, therefore, we understand the comprehensive approach that we need to take to measure outcomes and not our archaic forms of pure biophysical and psychosocial. Integrating quantitative and qualitative methods, I think, is crucial, and this is going to make a difference about us understanding value-based care and whether we are really providing impact into our patients. I hope you have found that useful, and contact me if you are interested in doing more research in this area. Thank you and have a great day.